Welcome everybody, and so thank you to join this. Actually, it's kind of like a third webinar in a way, Silica related webinar. You know, David originally had a meeting in the US, and then we had a joint international, WHWB international and US, but it was more general Silica, and now we've honed in onto artificial engineered stone and counter benchtops. So welcome everybody, but I've got a presentation. I can speak more just at the start of my presentation. I'll just thank everyone to volunteer your time and join, and also especially to the speakers up front. So thanks for joining.
Yeah, and let me be very clear that we have broken up this. The first one tonight is going to look at the severity of the problem and talk about prevention issues. And Kevin is going to host on the 13th of February another focused assessment looking at prevention, risk assessment, industrial hygiene. And we would like to invite everybody who's on the webinar now tonight to come and join us. We'll have a different group of speakers. Some will be in common and some won't be. And but again, I want to reiterate that you've got to sign up for them. You can't just simply log in and get involved. So let me start here and talk about what I'm going to speak about. What about the size of the silica countertop industry, the workers at risk, and the cost of the acute or accelerated silicosis treatment that are really in front of us and have drawn our attention to the severity of this issue. And I have to say something right up front. I am an epidemiologist and I'm not an economist. So some of the stuff that I will talk about, I've tried to give sources for, but in this context, you need to take everything I say when it has a dollar sign attached to it with a big degree or grain of salt. I also want to say that for everybody who's on Zoom with us, we are going to hold off on questions until we get to the roundtable. However, please feel free to use the Zoom chat to ask speaker questions. You can do that to the group as a whole, or you can send an email or send a chat question to the speaker herself or himself. This talk is, if you will, designed to set the stage for what's going to happen as I get moving. And I'm going to try and focus on the international and the US countertop industry data, again, with the caveats that I'm not an economist. I mentioned this part A and part B. Part B is going to be hosted by Dr. Hedges with me as second in command, which is just fine. And I would encourage all of you to come and join us again on the 13th of February. So, okay. So I believe we're talking about and facing an old and very serious problem. And some of you may have some experience with looking at some of these historical and not so historical kinds of issues, but I do want to say that we are facing a problem that's not new. Ramazzini, those of you who recognize him, he was the famous Italian occupational physician who's really credited with being the father of occupational health. There is a review of Ramazzini's stuff by Franco in 2021, and I would strongly recommend you might want to take a look at that. We also have the Gauley Bridge tunnel disaster between West Virginia and North Carolina that was described by a colleague in 1986, Dr. Cherniak, and a lot of the specific health problems that Cherniak is talking about is exactly what we're dealing with now. There's also the Vermont granite workers in the middle part of the last century in the 20th century. There's a later assessment from Midland, Odessa, Texas, amongst Mexican sandblasters. There's a lot of similarity between what they had to deal with and what we're going to talk about with regards to the countertop workers and the severity of their respiratory ailments. And then more current, up to the minute, if you will, sandblasting of blue jeans in Turkey that has been looked at by authors Akgun and Ergun in 2018. And I only bring these to your attention to state again, we are not talking about something that we don't know about. We are talking about something that we thought 10 years ago we had enough information to put into place prevention programs and awareness programs. And very sadly, that turns out to be an incorrect assumption. And we'll talk about that a little bit later in more detail. So here's a little bit of background on the Silica countertop. The US market, the market worldwide, apparently in 2019, 2020 was $89 billion and is now projected in the year 2027 to reach as much as 110.5 billion. What we know is that the demand for countertops, at least in the US, is expected to rise about 3.8% per year. And that's going to lead to a market in the United States of $42 billion. So you can see that if you look at the total worldwide market, a little bit less than half of that, according to my calculations, will be in the United States. We know that a major economic driver was the need to build and replace old countertops in residential kitchens and bathrooms, but that also extends to classrooms and museum laboratories where these countertops are being put into place and they're replacing, old stuff and leading to an upgrade and so on. But this is true in Europe, it's true in Asia, it's true in the US and Canada. What I am unclear about is what is going on in South America, but my sense is that they have an equally strong market. And if there are those of you who are on the call who could help me find some of the people involved in the countertop issues in South America and in Africa, I would be very pleased to do that. There is something that we also know about the market in the US, Canada, and Mexico. The demand for kitchen countertops has a strong growth pattern. And that's because a lot of people have this interest in either enlarging or remodeling kitchens. And this might be something that's a post-COVID impact. Nevertheless, we know that this is happening. The market for the countertop, we need to keep in mind that engineered stone materials, which I would consider to be much more on the fabricated side, they have a lot higher concentration, double the concentration of crystalline silica compared to about 45% in granite. And I found a recent, this is 2019 estimate from the Mortality and Morbidity Weekly report that there may be as many as 100,000 workers in the United States. And that probably includes a lot of this 8,700 smaller shops, with most business going on, as you might expect, in California, New York, Texas, Florida, and Illinois. And based on the reporting of Jim Morris, many of the workers who are now being diagnosed with acute and accelerated silicosis are young male, they're Spanish-speaking migrants who are aged now in their 30s and 40s. And in general, the countertop workers and by extension, their supervisors are not aware of the severity of the silica dust hazards, and they're not provided with engineering controls or even simple respirators. So what about the cost? Workers are diagnosed with severe silicosis, might not seek medical attention until symptoms are so severe and their disease is so far advanced that there is no opportunity for any reasonable clinical benefit. And we are aware in past episodes like that Texas sandblasting operation that these patients may return to their homes, they may not seek treatment or compensation and die, which is very, very sad. But this is part of the community and part of the issue that we need to look at. The only treatment for severe silicosis is a lung transplant operation. And in the US, typical cost for a lung transplant, I don't want to go through this, but the total is $886, nearly $900,000 without insurance. I have on the next slide a second look at this. This was looking at, with regards to lung transplants, something called a lung allocation score, which emphasizes the severity of the injury to the lung as a basis for choosing who receives this procedure. And it looks as if the cost has gone up to nearly $570,000 from $400 some thousand. But that has also led to an increased length of stay, daily charges, and disposition other than to home. This is from a paper by Maxwell et al. From 2015. There is also one other thing I just wanted to share with you. Using data from the California diatomaceous earthworkers, this is a group with well-known historic high silica exposure. Picciolo and colleagues from 2018 estimated the median years of life lost for all causes for non-malignant respiratory disease, which in many cases is silicosis, chronic silicosis, and lung cancer. And when they did the analysis using the data from the California diatomaceous earthworkers, for all causes of death, there was a loss of about a half a year for all causes of death. But for non-malignant respiratory disease, 3.2 years. And for lung cancer, the loss was 2.2 years. And in both of the latter two are an indication of a secondary impact on health, and would probably not be as directly relevant to the countertop workers who have a much more advanced and much more threatening to their health with acute and accelerated silicosis. So in conclusion, we know the disease burden is falling on basically unprotected countertop workers. It's shortening their lives and having a dreadful impact on the quality of whatever remaining life they have. We know the cost for a complete lung transplant can range from between $570,000 and $886,000. And we also know that these amounts of money are completely out of reach for workers who lack insurance. I didn't mention it, but the 3-year survival after lung transplant can be in the area of some 50%. And again, we're talking in our cases about these very young guys. That means there is a clarion call as we need to marshal our efforts to control the silica dust and prevent the respiratory disease that is plaguing this country. And the one other thing from both the US as well as the global perspective is we really need to get our arms around how much of an impact the countertop and silica disease issue is. We have some glimpses of this being quite severe, but we really haven't got as good an estimate as we would need going forward. And so with that, I think I'm going to end. Thank you all for your attention. Appreciate it.
No, listen, thanks very much for the invitation to present today and for us to be able to talk about the experience in Australia. So I'm going to start by talking about our experience in screening a very large number of workers in the benchtop industry in Australia. And in Australia, we did talk about benchtops. I know in the US, it's mostly talked about as countertops, but we are talking about the same thing. And then I'll hand over to Graham Edwards, who's going to be talking about this really in terms of policy interventions and the national task force that has been looking at this issue and occupational respiratory disease generally. So in the time that we have, I'm just going to run through a few sort of key points in terms of some of the insights we've had from screening these workers, timeline of the case identification in Australia, our understanding of the prevalence of silicosis in these large cohorts that have been screened, look at the associations between exposure, TARS, and silicosis, and then just touch on some of the limitations of these traditionally used screening investigations, the ILO chest X-ray and spirometry, and some of the limitations using those when screening these workers. So this is a graph that demonstrates the number of reported cases of artificial stone associated silicosis in Australia. And again, these are just the reported cases. We know that the actual number is far higher than this. But just to step you through a few key points in this graph. So we don't produce artificial stone in Australia. We import this from overseas. And it really started to come into the country in the early 2000s. And the industry really exploded because of the popularity of this material from about 2000 to 2015. So lots of new businesses popped up, lots of new workers going into this industry. So the first case of silicosis in this industry was reported in 2015 in Australia, the European Respiratory Society meeting, so not too long ago. And then we reported a series of 7 workers in OEM in 2018. And then really after that time, there was an increase in media attention about this issue, which I'll talk about in a moment. But this really was a big catalyst for increased pressure on regulatory agencies to do a lot more in this industry, to really focus on the industry, to investigate what was going on, to look at the hazard. And as part of this, to implement some free government-funded screening programs for workers in the industry, which I'll talk about. And really after the introduction of those programs, we've seen this really sharp increase, not surprisingly, in the number of cases of silicosis that have been identified. Now, again, official numbers are close to 600 cases, but really, the number is going to be far in exceedance of that. But as I mentioned, really the media was so important in terms of getting this on the agenda of the regulatory agencies. This is a material that was being used in the country for 15 plus years with really poor dust control measures and it going unnoticed. And so it really was workers talking about their situations. So, I give full credit to these workers that really put themselves on the line, talking to the media, telling them about the conditions and what the disease was like that they were facing and the uncertainty. And this really was a huge catalyst. And Anthony Weiss really was one of these workers that was so pivotal in doing this. And tragically, Anthony's died as a result of silicosis following this. So 2 of the largest screening programs have been run through Queensland, which is up here, and Dr. Edwards is from Queensland, will be speaking in a moment, and Victoria, where I am, down the bottom here. These are large programs. So the WorkCover Queensland program, as of December 2022, it screened a bit over 1,000 workers. So this is not a small sample size. And we're estimating probably in, like a state like Victoria, which is a bit bigger than Queensland, there's about 2,000 workers in the industry. So, 1,000 workers, and of that group, 204 with silicosis, 36 with progressive massive fibrosis. So disease prevalence of almost 23% in that large group. In Victoria, the program is similar, but it's linked to a research program that we run through Monash University. I'm not going to go through this in detail, but just to highlight a few issues with our screening program. So when this was developed back in about 2018, we felt at that time there wasn't enough evidence to perform a CT scan on everybody that came through the program. So we had some criteria that were required to be triggered to have the CT performed. And it ended up that 77% of those attending required a CT scan and had an assessment by a respiratory physician. So in terms of the outcomes from that screening, these are interim data. We've just submitted the final data for publication currently, but the results are very similar in the final analysis as they are in this interim analysis. So at that time, there were 402 screened workers. Again, large size, and they had a final diagnosis assigned. And out of that 402, so 107 with silicosis, so 26.6%. So quite similar prevalence to what we're seeing in the Queensland program. We take quite comprehensive occupational exposure questionnaire histories when we assess these workers. And what we've looked at is the association between duration of time in the industry, and in particular, the level of exposure to dry processing of stone. And not surprisingly, we do see a dose-response relationship with more intense exposure to dry processing and longer duration being associated with silicosis. But, even in the group with low exposure, so low to medium exposure, so, very little exposure to dry processing, shorter duration, still a prevalence of 3% of silicosis in that group. But when you get to that high level of exposure, so 30% prevalence of disease, which is really shocking. In terms of the jobs held and association with silicosis, the prevalence of disease has been highest in installers. And certainly prior to 2019 here in Victoria, a lot of cutting of stone was done on site as part of the installation process. So a lot of the cutouts were performed on site, uncontrolled, with exposure to dust. And then the factory machinists working in the factory with hand tools also having a high prevalence. Just a quick snapshot about some of about the industry itself. So these are all screening participants, very male-dominated industry. 93% of screened workers were male. The median age of 35 years. High prevalence of smoking, so 34% current smokers, which is significantly higher than the background rate in Australian men. And certainly here in Victoria, we have a lot of workers that come from overseas, in particular from Asian countries. So, certainly in my clinic, I see a lot of workers that have been refugees from Vietnam that come to Australia and have developed silicosis working here in Australia, which is really, completely unacceptable. In terms of dry processing, has been associated with such enormous levels of silica exposure. And this is a practice that has been so widespread in this industry for such a long period of time. So what we found prior to 2019, over 60% of workers were in an environment where dry processing was happening for over a quarter of their work time. And so almost 20% reported that 100% of their work time they were dry processing, or somebody else in the environment was dry processing. So there's been a lot of work from the regulatory agency to try to stamp out dry processing over the last couple of years. And we are seeing improvements in terms of that. It doesn't eliminate the primary hazard, which is the material itself with such a high silica content, but it does go some way to reduce exposure. And this is just a couple of pictures that patients of mine have provided of themselves, just covered in dust when they have been dry processing this stone. So we can see this worker here just with dust all over their clothes with a half-face respirator, and this worker here. And, a lot of these workers have beards and, the dust gets under it. They have to use an air gun to blow the dust out of the filters. It just gets so clogged with the quantity that's produced. And just briefly with screening investigations. So, we know that spirometry and the ILO chest X-ray have really been the cornerstone of investigation screening silica-exposed workers. Looking at our results, certainly when you look at the mean values for screened workers with silicosis, for the basic spirometric parameters, they're well above 80%. So if you use 80% cutoff as the level that you would be using to identify somebody with possible silicosis, you're going to be missing nearly all of them. Really only those with very advanced disease have impaired lung function. Similarly with the chest X-ray, the ILO chest X-ray, and all our chest X-rays have been reported by a qualified B reader. And so what we've found was the 28 out of 107, so 26% of those with silicosis, with simple silicosis, had an ILO category 0 chest X-rays, so a negative screening chest X-ray, who were diagnosed by a CT and a respiratory physician. So, you know, this is just an indication of the severity or the spread of radiological findings that we see on CT. So listen, it's no wonder why some of these workers with simple silicosis are missed on chest X-ray. They may have very mild disease, just a few small nodules. They may have a lot of ground glass subtle nodules on CT, which will just not be detected by chest X-ray. But, you know, we also see, you know, these patients coming in through screening with really advanced disease. So, you know, remember, this is a young workforce. You know, they often have, you know, really significant respiratory reserve. So they may have really severe radiological disease, but have very little symptoms at the time. So screening has been so vital. And just briefly in conclusion, so proactive government-funded screening has really been crucial to identify the number of workers that are affected. You know, our estimate of prevalence in this industry, and this is through screening a large number of workers, is about 25%. So even taking a conservative 20% with that 100,000 that are in the US, that's 20,000 workers with silicosis at this point in time, potentially in the US. And I really don't think that's, you know, that's an overestimation. I think it's probably an underestimation in some respects. The mean age was 42 of those diagnosed with silicosis, so young people, and really high rates in factory machinists and installers, and dry processing has been so common. So, so I'll hand over to you, Graham, to carry on from here in terms of some of the rest of our experience in Australia.
So hopefully you can see my screen now. So I'm going to cover the insights and challenges that the Dust Disease Task Force that was set up here in Australia essentially developed as a result of the work that Ryan has already alluded to. All right, so what have we learnt? Where are we now? Historically in Australia, occupational environmental medicine did not have a home within the regulatory framework. Over the last 4 or 5 decades, the intelligence around occupational environmental medicine had quite significantly diminished. So we don't have any full-time occupational environmental physicians in any of the regulatory institutions in the Federation of Australian States and Territories. So we've actually had a significant development in the Australian setting in just actually having a home within the Office of the Health Protection within the Department of Health. From my perspective, any case of silicosis is a sentinel feature of a failed regulatory system. So I don't have to tell this group that there is a wide variety of dusts that can cause harm to the workforce. And from a strategic perspective, interventions that work to control respirable crystalline silica will also control exposures to the full scope of the preventable occupational respiratory diseases. So I see silica and silicosis as sentinel of system responses. And if we see any case of silicosis, then it means that there's been a failure of the regulatory environment. So just declaration of conflicts of interest. I was the chair of the working party that developed the national guidance for doctors that was commissioned, but I'm not speaking on behalf of the task force, nor am I speaking on behalf of the College of Physicians or the Faculty of Occupational Environmental Medicine. Numbers have already been covered by Ryan, so I'm not going to spend more time on that. He's already covered that side of things. The initial task force recommendations, this is back in January 2020, so now getting to 3 years ago. What did we identify? There was a need for developing national guidance for the doctors, We needed a strategic approach to research, establishment of a disease registry, which does not exist even today. It's still on the drawing board, meeting its final stages of development. And we needed a national approach to detect the problems. The final recommendations came out in July 2021, and we made those recommendations just for speed and interest. This presentation is available for those who want it. So the National Silicosis Prevention Strategy, and there's a national action plan, has been developed. And as I mentioned before, under the Office of the Chief Medical Officer of Australia, their Environmental Health Group, we now exist in the Office of Health Protection and Response, in the Health Protection Policy branch, and then we have a Dust Diseases Policy and Project section. So only yesterday, so hot off the press, another bucket of money totaling $3.95 million has been announced by our federal health minister to fund the National Silicosis Prevention and National Action Plan. So the national guidance document was only published a year ago, and it translates the task force findings and observations into practical guidance for the healthcare profession, and it's intended to inform current clinical practice and future guidelines in the statutory requirements. And I would encourage anyone interested in the subject matter to read through that document, because not only is it applicable to the Australian setting, but there's lessons to be learnt in all jurisdictions across the globe. One of the key elements from my perspective as an occupational physician is that labels matter, and I'll explain why in a moment. But basically, fear and anxiety in the workforce around the diagnosis is as important a hazard to the health and well-being of the workforce as is the actual toxicity of the respired crystalline silica. So, and the early progressive disease, with better detection, we're going to detect these workers at a point where they are asymptomatic. And when you're trying to deal with interventions in the asymptomatic individual, it adds another complexity to how do you address the problem. And it's when they're asymptomatic, as Ryan has already illustrated, by the time they become symptomatic, it's already too late. And that's what the evidence over the decades has shown, that there is no effective treatment for these workers once they become symptomatic. So from exposure to disease, this diagram is in actually the national guidance document, and we're certainly highlighting the importance of distinguishing between simple silicosis, complicated silicosis, and then the various forms of complicated silicosis. So while we focus a lot on accelerated silicosis, because that's been the tagline that has created the media attention and the consequences of it, we have to remember that there's also another cohort of workers who don't have the rapidly progressive disease, who we need to manage in terms of their workability, their occupational capacity, and lifestyle implications. So progression does not occur in all cases that have been diagnosed with less than 10 years since first exposure. So Leon Jimenez and colleagues appropriately noted that 56% progressed 2 or more ILO subcategories within their 4-year follow-up period. But indirectly, when you drill down into their data set, there is a significant proportion of people who are diagnosed with silicosis who don't progress. And that's reflected in the growing body of literature that's available. So primary diagnosis, basically fit into three categories: those who have no detectable disease yet, they've had the exposure, they're highly likely to develop the disease at some time during their remaining life, but they don't have the disease at the time of the screening program. And then we've got the secondary labels. So just to illustrate that not all progressive massive fibrosis progresses. This is a patient of mine that I was following for 3 years. And at first diagnosis, he had PMF, that's in 2019, but by January 2021, there had been no progression, even though his exposure time was less than 10 years. The other headline issues that came out of the task force deliberations meant that we needed a better way of stratifying the exposure assessment, so semi-quantitative tools to better assess that. There's a exposure risk matrix that we developed. The lung function testing, Ryan's already mentioned that. The important thing is that the action threshold that we've identified, if you wait until there's a 15% decline in their either their FE1 or FEC relative to the GLI reference values, then it's already too late. They're actually got substantial damage occurring. So we've recommended that the action threshold should be a 10% decline once you actually start screening these people, monitoring their health and well-being. We've already identified that the ILO chest X-ray is an insensitive screening tool, and case management needs to be a shared decision process. So just in terms of the exposure dose index, that's an illustration again from our national guidance document that gives you an idea of what you can do in those who have exposure. And then there's risk stratification based upon that. And I have to acknowledge the work of Ryan and his colleagues, Deborah Glass, in particular, in developing this particular instrument. So the serial decline, I've mentioned already, so I won't dwell on that. And a key element in managing the workforce is understanding that it is a shared decision-making process. And as we can't instruct, we can't dictate to our patients, what we need to do is work with them and look at the best solution for their particular scenario. So it's a work in progress. So since the establishment of the task force, there's been mobilization of funds. So over $15 million now has been mobilized in research and education. We now have an Office of Health and a home in the Office of Health Protection. There's regulatory reform that's ongoing. We've got the guidance for doctors. We've got the establishment of a disease registry, and we've got the funding as of yesterday on the National Silicosis Prevention Strategy and Action Plan. So I've finished with this particular slide from, again, as you saw at the start of the presentation, silicosis, every case is in my view, is a evidence of system failure. Back to the next presenter.
I was muted. Thank you very much. Next, it looks like findings in the US and California.
I will go ahead and share my screen. Okay, can everyone see my screen?
Yes.
And hear me okay? Please let me know if you can't at any point. So my name is Dr. Fazio Jane, and I am presenting on behalf of many collaborators listed here, Dr. Gandhi, Dr. Heinzerling-Kammengar, Dr. Afif, and Dr. Cummings and Dr. Harrison, who I think the majority of which are on the call. And I'm tasked with describing silicosis in the United States and California, of which most of our cases are immigrants. And so I'm going to go through the agenda of what I'm going to talk about today. Okay. So first we'll talk about the progression of case finding in the US and California. Then we'll talk about the Occupational Safety and Health Administration Silica standard in the United States. We'll talk about the California OSHA Special Emphasis Program on silicosis that was developed. I'll go through our patient data from California over the last couple of years, and we'll talk briefly about a up and coming research project in California looking at artificial stone and silicosis. So briefly, the history of US case finding started in 2014 with the first reported case of silicosis due to engineered stone in Texas, reported to the Department of Public Health. This man was a Hispanic gentleman in his 30s who worked as a polisher, laminator, and fabricator, and he'd been exposed for about 10 years working with these materials. In California, the first case was found in 2019 with the California Department of Public Health identifying this case through hospital discharge records. He was hospitalized in 2017, and kind of going back in time was discovered that he'd worked from 2004 to 2013, employed at one of the countertop fabrication shops. Was diagnosed in 2013. So this first case in California then led to discovery of 2 other cases that were also identified through hospital discharge data and workplace investigation of this individual case. All of them were young Hispanic immigrant men, and the 2 cases in red represent that those cases were fatal. So this prompted a lot of concern, and along with colleagues from other states, we started to kind of get more interest in this throughout the country. Those 3 initial cases then prompted both the California Department of Public Health and the regulating institution, which is our California OSHA, to perform workplace investigations of the 2 locations of that one company, and perform X-ray screening and spirometry, at which point from that process, 5 other patients were diagnosed. The median age of those cases detected by screening was 37 years old. And so within that workplace, there was a prevalence of 12% of silicosis within just that workplace. And then you can see the map of California here. Those stars represent kind of the 2 locations. So simultaneously, the CDC came out with this morbidity and mortality weekly report identifying cases throughout the country. We have 1 in Washington, 6 in California at the time this was published, 7 in Colorado, and 4 in Texas. The majority, actually all except for, I believe, 2, were Hispanic immigrant men. So this all prompted OSHA regulation and a development of a California special emphasis program on silicosis. So I just wanted to briefly go over what as it stands today, what the OSHA Silica standard is for employees in the United States, how it's changed. So in 2016, OSHA reduced the permissible exposure level of respirable crystalline silica from 250 micrograms per cubic meter to 50 micrograms per cubic meter averaged over an 8-hour shift. So decreased it by 5 times. The standard that requires employers to do all of the following, including determining the amount of exposure that their workers are exposed to, whether it's above the action level or the PEL, required to use dust controls and safer work measures. They are required to have an exposure control plan. They are required to train workers on health effects of working with these materials. And they're required to offer and pay for medical exams, including mandated screening for anyone who has been exposed above the PEL or action level at least every 3 years. And they're also required to keep records of exposures and medical exams. And there are a lot of reasons that I'll get into shortly of why we don't think much of this is happening. So during the special emphasis program, which ran from 2019 to 2020, Cal OSHA opened inspections in 106 of workplaces in California where personal air sampling was able to be performed. Advanced too ahead of myself here. But you can see that the results here show 152 employee silica exposure measurements were made at the inspected companies, and 25% of the exposures were above the PEL and 11% were between the action level and the PEL. So many of these folks are more exposed than they should be. Another way to look at it is that 47 companies were sampled and 51% had at least one exposure above the PEL. And 15% had no exposures above the PEL, but at least one between the action level and the PEL. They also, this group looked at worker interviews and found that many are young, median age of 39, had short work tenure, about 3.8 years on average. Almost 40% were Spanish speaking, 91% performed dust generating tasks, and a quarter using dry methods. Most of them were not informed of air sampling, and very few were fit tested or offered medical exams. So I wanted to now transition into the newer patient data that we're putting together for publication shortly in California. So in a lot of ways, in the United States, we're very behind Australia in our efforts because we don't have a nationwide system at all for surveillance or an organized reporting or surveillance system. So the identification of cases in California has been in some ways piecemeal. We have 8 people that were identified on worksite surveillance. Those were the ones that I discussed in the beginning of this talk, as well as 7 that were identified through hospital discharge data. And then 37 of them are, word of mouth. And many of them are actually my patients. And that's how I got into this, by seeing a multitude of patients in my practice in a county hospital in Los Angeles called Olive View UCLA County Hospital. So myself and all of my colleagues have helped identify and report these cases in collaboration with the Department of Public Health. So there are about 9 other counties in California besides Los Angeles County where we have found cases. So we think that all of this is just the tip of the iceberg, and statewide, there are likely many, many more cases, and nationwide that we just do not have data on. So for perspective, for those of you that don't know geography of California, which is understandable, this map is Los Angeles County, and Olive View UCLA Medical Center is this hospital up here in the valley. And the valley up here is a very industrial area of Los Angeles. And so if you run a search of that county, this is only the first 20 hits, but there are over, all these little dots are stone fabrication shops, and there's over 100, likely 100, 150 in that area alone. So a very industrial area, which is why I think we're seeing so many of our patients at the hospital that I work at as a pulmonologist. So this is a representation of the timeline of diagnoses in California. Obviously, this is not epidemiological data, but just case reporting. Most of the cases that we have been found in the last 4 years, diagnosed in the last 4 years, and all since 2010. Some of the data from our 52 cases that we've put together is quite similar to some of the other data. So we have a pretty young median age of diagnosis, 45 years old, with the interquartile range of 40 to 49. We have all but one were Latino immigrants. And this pie chart over here shows you where they are from, mainly Mexico, El Salvador, and other countries in Central America. Unlike the Australia data, it seems most of these folks have a relatively small amount of smoking history. Although a third of them smoke, they have very few pack year history, so 3.5 pack years on average. And then the salient feature here is that the large vast majority are either uninsured or underinsured. which here we have 19% that are uninsured, nearly 40% that are on what's called restricted Medi-Cal, which is kind of a proxy for undocumented worker status, because it's only available to folks that it's sort of like an emergency public health care for folks that do not qualify for the full scope government care because of immigration status. And then we have some that are on workers' compensation, and about almost 30% that are insured or fully insured. So some occupational data from this cohort. The years working in engineered stone, a median is about 15 years. From 10 to 20 was our interquartile range. Many are still working after diagnosis. So almost half, even after they would have been diagnosed, continue to work despite being, counseled on it, likely because of social factors. And then the lack of engineering controls is very profound in this population as well. Only about 44% endorsed using any water suppression methods, and even less so in terms of exhaust ventilation or dust collection systems, maybe only 20%. In terms of respirator use, all of them used respirators of different sorts, sometimes or always, although 3/4 only used respirators sometimes. However, the type of respirator used is really quite sad. Many of which only used disposable N95s. Some of them even only used like the surgical masks that we have been using, the droplet masks for COVID, et cetera. And then some have alternated those with half face respirators that are the more correct mask. And most of them, anecdotally, this isn't in this data, most of them do not get those provided by their employer as they should. And then we also asked about number of employees working in the workshop. And most of these workshops are quite small. About half have less than 10 people, and half are about 10 to 50 people. And I think there's been data looking at size of workshop, predicting worsened dust exposure, likely due to not having the types of not being able to afford the types of overhead that are required to afford the more useful, the more effective preventive controls, exposure controls. A few other patient characteristics that we have. In this cohort, 85% of patients are symptomatic. The other 15 usually presented to the hospital for a different reason and were found to have abnormalities on their X-ray, or were found during the screening, workplace surveillance. Unsurprisingly, the larger majority had cough and shortness of breath, but even some, had presented with pneumothorax or collapsed lung. And then here's a chart of just the severity of abnormal lung function in our cohort. You can see that the majority of patients at time of diagnosis did have some, from mild to very severe, but did have some lung function decline or abnormality at the time of diagnosis. Probably even more profound than this is just the proportion that presented with progressive massive fibrosis at the time of diagnosis. This is an example CAT scan of one of my patients. And at the time of follow-up of this study, 15% of cases were fatal, and then 15 are requiring supplemental oxygen at this time of follow-up. So we can see that this is a pretty, we really have not caught folks in early stage of disease, probably due to a number of factors, such as immigration and access to healthcare. So I wanted to briefly mention a project that is quite a collaboration between the Department of Public Health in California, the California Labor Lab, UCSF, all of you at the hospital where I work, which is a 5-year study which aims to increase workplace education. It also aims to look at medical system diagnosis. So kind of bouncing off the last talk, the main question here is, can we screen workers, and is screening with an X-ray or a CT chest more effective in catching those folks early? Likely it is, and then in a place where we're able to actually make a change while folks are asymptomatic. So it's kind of getting at that identifying asymptomatic disease with a CT chest rather than just an X-ray, and also with a full pulmonary function test, including DLCO measurement as well. And then to continue improving surveillance efforts with discussion of making silicosis due to engineered stone a reportable disease, which is currently underway. So this is a list of all of our collaborators on this project. So I'm hopeful that we will have a lot more data to share in the future once this gets enrolled, once we start enrolling patients and having more data from this. So in conclusion, in California and the US, we've seen an exponential increase in identified cases of pulmonary silicosis due to fabrication of engineered stone, along with high levels of reported dust exposure. At-risk workers, at least in California and likely the United States, are predominantly young Latino immigrants who are underinsured and often present with advanced stages of disease. And really a multi-pronged approach, including mandatory case reporting, industry regulation, and disease surveillance, and policy action is needed to protect vulnerable workers going forward. So I just wanted to thank all of the collaborators on this effort, from CDPH, my colleagues at Olive View, UCLA in the Pulmonary Division, California Labor Lab, and Cal OSHA as well for meeting with us frequently. Here's my references. Thank you.
Well, you're next on the agenda.
Okay.
Sorry, I skipped. Communicating risk to Spanish-speaking workers, and she's from the Migrant Clinicians Network. So take it away, Alma.
But thank you for having me. My name is Salma Galvan, and I am the Director of Community Training and Engagement with MCN. And part of what I do a lot is to develop curriculum, develop material for different kind of public health issues. So what I'm going to share with you very briefly, it's something that we have learned doing this study evaluation of silicosis alerts for workers and clinicians that we did in 2020. And along with some of the findings that we have in my work developing material. So let me share with you that in 2020 we conduct like 18 virtual interviews with clinicians and in-person interviews with 8 Spanish-speaking construction workers. We did a focus group with 7 Spanish-speaking construction workers and 2 key informants with people that work with them. And what we learned from reviewing these alerts that were for construction workers on Silica and alerts for the physicians or clinicians to share with the patients, we learned that basically all these materials are based on the needs of the creators, not on the workers' needs and characteristics of the workers. We learned that the materials are not appealing at all. So if they got something and that they cannot read, they easily can throw it away. We also learned that a lot of the workers read, but do not understand, do not comprehend what they are telling. Why? Because they use a lot of clinical terms that are not related to their literacy level and comprehension level. And you know very well probably that the data along the US and along Latin America, you know, the literacy level is low. So we need to really take into account that. Also, we found that there is no built network within the health center to follow up with if somebody wants to look for more information or more help, and that we have a lot of work to do. And what is the the things that we were thinking about doing and that we recommend, that we need to really, really adjust the content that you are trying to do, especially for Hispanic or people that speak Spanish, mainly because it's, my first language is Spanish, and I usually do not do translation. That's a very, very important part. We create materials and the language of the person. We call it transcreation, which is very, very different from translating. So what we need to do is to, when you are speaking with these Latino workers or people that speak Spanish, is look at the cultural practices and values and see what is the literal level that you are using. Because you can explain things, but if you use words that are not related to what they know, I mean, you are missing the point there with them. And you need to really understand what is the origin. For example, if you are reaching out to somebody that is from Mexico and somebody from El Salvador and somebody from the Caribbean that speak Spanish, the language is very, very different. They can call one thing in very different ways. So you really need to do interventions that are aimed to the person that you are trying to reach. Also, when we develop those educational materials, we recommend that we use a lot of pictures. You know, it is much better than all the data that you can provide or the language that you can provide. Using graphics is very important. Fewer words. You know, the less words that you can is the best that you can do. And if you are using graphics, try to do characters that are like them, not cartoons, probably not a photo, but something in the middle. And you need to, of course, do a needs assessment when you do that. Also try to eliminate the more that you can the clinical terminology, and I will show you some examples, because that could be definitely something that they avoid. They can tell you that yes, 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 but they do not grasp what you are saying. I think it's better to describe the term that you are doing, that you are trying to communicate with them. Also use colloquial language. So that's very, very important, you know, so you can make a click with them in communicating risk. Using long fonts, using color in the things that you are trying to do and in the trainings that you are trying to. Also explore ways to communicate, for example, develop videos, podcasts, use social media, WhatsApp, you know, all those different things. Is not only, I mean, this world right now, they use a lot the phone and short videos is one of the best things, or radio programs too, you know, because they listen to the music. Go to those radio stations. Another, here's another, some examples in some of the materials that we read. For example, Silica is nothing. I mean, there's something that they don't understand. What is it? Yes, the word can have a meaning for the doctor, the physician, but not for them. So we suggest to use, you know, polvo. What about anexo? Something that is next to it or is connected to, you know, what is the origin, punto de origen, de donde viene, you know, use different words. For example, filtro EPA, you are telling them to use this filter to cover themselves and protect themselves, but they, I mean, it's something that is not related to them. So you need to use máscara, mascarilla, something like that. Even words that you are saying, like if you are exposed to to silica for long periods of time, what is prolongado, you know? What is that? You need to use very simple terms like tiempo largo, mucho tiempo, things like that. Particles, that's another thing. What is that? You need to really describe. So that's an example of some of the words that we find on those materials. But to continue with what we learn is that we need to facilitate educational interventions. And I was very happy to hear, this project that you just programmed or research that you just mentioned, because it's very important to do interventions, long-time interventions using community health workers, people that are related to them or that know their values, the way to do it, and help them to identify early symptoms. I know that sometimes, you can work with Silica for 10 years without noticing anything, but they really need to understand their body and pay attention to it. Remember that these are immigrants and migrants, that they have a lot of pressure, they don't have insurance, they don't have a lot of the conditions that it's easy for people to pick it up, something that is happening different in your body. They really need to be attentive to what they are doing. Also use the community health workers or outreach workers, whatever you call it, to work alongside with the community organizations. If you are a medical center and you are trying to do an intervention, reach out to community-based organizations that know what the workers are thinking or doing, or where they get together. Also develop resources and referrals, easy ways for them, if they have questions, where they can go. But somebody that speak their language, that understand their language is very, very important. And speak with them with trust and with empathy. That's very, very important. So you need to really train outreach workers on strategies and how to approach workers, but also you need to teach or train physicians and how to approach the subject to them. Usually they will say no, and no, I don't feel this, I don't feel that, because nobody wants to lose face or to say that they don't feel well. You really need to always provide the information. If you know that he works in construction, not only with with this stone, you need to let them, because what I see is a lot of people that work in construction, especially in demolition, they are exposed a lot to all these different kind of dust and particles, and not only silica, but other ones. So, and the last thing that I want to say is that it is very promising, doing materials that are colorful, nice, but all this requires time. Right? It's not an easy thing. You need to know who you are going to talk, from where they are, do a little bit of needs assessment. There is a whole process on developing this. And not only that a clinician, put all the points in a long list and give it to them. You need to develop training that meet the people where they are, not where you are, which is one of the biggest mistakes that we do. We need to learn from our mistakes. And because this is not about us, it's about them. It's about their lives. And it's not only a project for us, it's their lives that are there. And when you develop materials, you really need to try and test with the people. Get people that it's versed in developing this kind of materials. Get people that know the community. Get some of the same workers there to your project from the beginning. not at the end, from the beginning, so they can give you ideas of how to deliver the information that you want to deliver to them. And again, my best practice is not to do translations. Do not do translations. Do create materials in their own language with their own values, and we will be better off doing. So thank you. I don't know.
That was great. No, that was really good. Thank you very much.
Okay.
All right, so next is Gerald Abraham, pathology issues of acute silicosis.
So thanks so much, David, for inviting me to participate in this, and to everybody who's contributed so much to this. I'm not going to be reviewing the pathology literature. There's quite a bit of it, individual case reports and excellent studies from very many places around the world. My disclosure is that I have been involved in medical legal cases, but mostly it's been research projects starting long ago, and with my medical school UCSF classmate, Stephen Weisenfeld, who's on this call as well, looking at the sandblasters. So briefly, what I wanted to do here is to go through something about the dust and the pathology observed in silicosis cases that I think are relevant to these artificial stone exposures and some of the lessons learned from that. And mostly I've used light microscopy as well as scanning electron microscopy and analysis. So I'm going to show you the artificial stone material because I wanted to see what was actually inside of it before grinding it or anything like that. And some examples from accelerated and acute silicosis, realizing the very definitions of this, some are based on duration of exposure and latency till recognition. And those are sometimes different from the pathology definitions. So there's not a unified standard for that yet. The pathology often uses the presence of alveolar proteinosis as evidence for acute silicosis, but it's not always detected in these cases, and especially in small biopsies. And also protenosis may be seen in some chronic silicosis and PMF cases unrelated to acute exposures. Pathology in the accelerated silicosis in these stoneworkers seems similar to what we have seen in rapidly progressive pneumoconiosis in coal miners, where there's extensive silica exposure now, and unfortunately. Sandblasters, stone grinders have similar pathology. Oops. The most striking feature for the pathologist that separates these from classic silicosis is the intense cellular interstitial inflammation, which has macrophages containing dust often overlooked and underreported by pathologists, sadly. The pathologists are not trained to look for these things in most training programs. They don't use polarized light even, and they're not interested except diagnosing cancers. That's a generalization, but it's basically true. There's not much on their board exams related to environmental or occupational pathology. So the fibrosis that is seen in these cases is variable. Sometimes there's developing cellular silicotic nodules that are often misinterpreted as other kinds of granulomas and not recognized as early silicotic granulomas or nodules. So here's an example of Caesar stone from a leftover kitchen project, and I just fractured some to see what it looked like inside. And this is what it looks like inside. There's innumerable very small particles in the matrix, but there's also large particles that give it some of the surface sheen, I imagine, that are silicates and even talc in this particular sample. And Dr. Ramkissoon, whose name I spelled wrong here, I'm sorry, has done an excellent study, which everybody should probably look at, coming from Australia in Adelaide. And on the left is one of the cascade impactor samples of respirable dust, less than 4 microns aerodynamic diameter. And this is what the dust looks like in that sample. You can see all these very sharp fractured silica particles. And here, in a lung section from somebody who'd worked with artificial stone or similar particles. So that's not too surprising, but we really aren't surprised that there's a connection between what people are feeling and what's found in their lungs. Dr. Deller was kind enough to send me a few of the transbronchial biopsies from some of the Australian stoneworker cases, and you can see they're small samples. You don't often see great silicotic nodules. You see interstitial disease. Sometimes you see a bronchial wall and some relatively normal parenchyma, and sometimes you'll see this interstitial pattern. So it's hard to work with that only. Here's a sample of a PMF fatal case of a stoneworker from the US, and you can see these large areas of massive fibrosis, and a lot of the material is actually confluent silicotic nodules that you can see here at a low magnification. On the right are confluent silicotic nodules, not completely well formed. It's such a active process. And also there's air spaces with proteinosis, as you can see here. So here's some air spaces with proteinosis confirmed by PAS staining. There's also edges of silicotic nodules you can see here. And of course, with polarized light, you see innumerable strongly and weakly birefringent particles. So for pathologists, they'll often not see the silica particles because they don't have a bright enough light source. So they'll say no polarizable, which is the wrong term. They'll say no, they should say no birefringent particles identified. So don't trust the reports. Go look at the slides with your pathologists, for those of you who are clinicians, and make sure that you can see with their polarized light the internal control, which is collagen, which is weakly birefringent. And the silica particles are these very, very faint ones that are weaker in birefringence than collagen. So it's very easy to have a false negative report for a polarized light examination. And here's what I was mentioning. This is from a very sad case of an accelerated silicosis in a 28-year-old miner from West Virginia who had worked for just 6 years doing a lot of work at the face with roof bolting. And he showed this intense diffuse interstitial process, sometimes with parabronchiolar pattern recognizable, as well as here. There were some developing early silicotic nodules. And in the very cellular areas where the nodules are still developing, you can see the birefringent particles very easily. The concentrations of dust in these lungs were done two ways. One is looking at the dust in situ and also collecting dust on a filter after digesting the lungs. And the numbers here represent particles per cubic centimeter of tissue. So it's a volumetric method. And you can see that in this particular miner, these numbers are 5 orders of magnitude really higher than the background, which are maybe 1 to 10 million particles per cubic centimeter. These are close to a trillion. Some of them go up to a trillion, 10 to the 12th particles. The percentage of silicates is not as high. In these, it's 80% silicates and it's 10%, or 20% silica roughly. This is the condition of the sandblasters in Texas that we studied years ago. No process control, no personal protection. And you can see PMF developing. In the rest of the lung, there are multiple small silicotic nodules and interstitial changes as well. The important point was made earlier that the plain chest X-ray is often negative. This one's not completely negative, but there's striking findings on CT scan. And this is no longer used, but gallium scan showed the intense inflammation in the lung. It would show up now with PET scans, but I'm sure that's not part of any screening at this point. These are the sample range of pathology you could see in these sandblasters, from minimal changes of some parabronchiolar dust and fibrosis to diffuse fibrosis to developing silicotic nodules with focal proteinosis to these cellular nodules. This was seen in a transbronchial biopsy, and some dust, not often easy to see without good polarized light. And then in the massive fibrosis area, silicotic type with multiple well-formed and less well-formed silicotic nodules. The important thing to know that was touched on by Ryan Hoy earlier, important to look at the work process. In the sandblasters in Texas, they used recycled sand over and over until it was too fine to use. And here's some pictures of recycled sand and new sand kindly sent to me from UK by Dr. Ferry from a case that she was looking at. The new sand has nice, large particles of silica. The recycled sand gets finer and finer and doesn't even settle out of solution. So this is what people are exposed to depending on the work processes. So the work processes are very important. And this shows up very nicely here, again, about work process. These are the results of the silica concentrations in the 46 biopsies we looked at in the Texas sandblasters. And on the left, when we look at the whole group, there's not a good correlation between duration of exposure and the amount of silica. But when we break it down to those that use the recycled sand, shown blue, and the rest of them that worked with sand that wasn't as much recycled, you see orders of magnitude difference, but a dose response for both with the duration and with the amount of silica. And you can see the ones that use recycled sand had much higher silica concentrations with shorter duration of sandblasting. So this is really important in all the studies that Dr. Hoy referred to and others about looking at the work process in one part of a place to another or one company to another. So for comparison now, here's a granite worker with massive fibrosis, and in that lung, there's much less diffuse interstitial formation, but more classic silicotic nodules, although there's little foci of proteinuria still seen in this kind of case. In a US coal miner, we can see this massive fibrosis that's pigmented. It looks very dark, but still, this is the silicotic type of PMF where there's confluent silicotic nodules, and the amount of dust is disproportionately not dark, as you'd expect from looking at the lung grossly. The interstitial fibrosis and cellularity is marked here. And we can see areas like this that are sometimes interpreted by pathologists as some sort of interstitial fibroblastic or proliferative process, and they don't even mention dust that all of us who are sensitized to this see easily. And they don't use polarized light. If you use polarized light, you can see dust in the air spaces and dust in the interstitial macrophages and an occasional silicotic nodule. This is just close up on it. So the lessons that I've learned from this is that the respirable dust, not surprisingly, that's evident if you looked at air samples, is the same as what you see in the lungs and in lymph nodes of the exposed workers. The pathology seen is really a mix of acute and accelerated silicosis and some developing PMF. The range of pathology is similar to what's seen in sandblasters and coal miners with rapidly progressive pneumoconiosis. And proteinuria is often seen, but may be missed on limited biopsies. You may find samples that show proteinaceous material in lavage samples, but remember the lavage only samples what's in the airway. It doesn't sample the interstitium. The biopsies are not required. So here I am as a pathologist saying you don't really need biopsies, but unfortunately they have been done and they provide documentation. This disease, as Dr. Edwards mentioned, should not exist anymore, but the chest x-ray often being false negative, people do get biopsies early on in the stage before the x-ray becomes positive. And the mineralogic analysis of mixed exposures can quantify the amounts and types of different particles present and can reveal the most important relationships. In our sandblasters, I didn't have time to show the data, but when we did with Dr. Crawford, who's also on this call, extensive multivariable analysis, we could show very well that looking at the silica concentration and the aluminum silicate concentration and the concentration of metal particles, the only one that correlated strongly with the radiology, with the physiology, and with the pathology was the silica concentration. So it's really useful to have that information, but again, we know that silica is bad. So the work practices are an important thing to analyze from one place to another. And we all know we're seeing something that we're, I guess, privileged to study at this point, but we shouldn't be doing this, we should be studying other unknown diseases.
Great, thank you very much. Next, we have the fun part, well, the more fun part, roundtable and questions, reaching workers and employers prevention. David, do you want to kind of kick it off? We have the speakers are Manny de Oliveira, Ryan Hoy, Salma Galvan, Gerald Abraham, and David Weissman, I think.
Well, yeah, and let me just ask, because I don't see them, is Mr. de Oliveira on the line? There he is. Thank you, Manny.
Oh, I thought I saw him there.
Very good. I am hopeful that you and Jim Morris can speak with us. I know that Jim sent me an email. He's in Texas, and they've had terrible ice storms there. And he said there was a chance he might not be able to be on. Jim, are you with us? So Manny, I believe this is your brother or your son who's with you?
Yes, my son is Sean de Oliveira. He's here to my right.
Excellent. I am really pleased that you're with us, and I mean that quite sincerely. You are an owner of a countertop factory, if I understand correctly, in Northern California. And if I understand correctly, you have invested a good bit of your capital to upgrade your whole process with a strong focus on dust control for your workers. Can you briefly tell us a little bit more about what you do, the types of products that you have, and the type of activities that that you've put into place? We are all very keen to hear this, because you're really where the quote unquote the rubber meets the road, and we really am grateful, and I want to say on my behalf, delighted to have you on our program for sure.
Yeah. Thank you very much. It's very interesting what I've seen and heard so far throughout this webinar, but we work a lot with the Spanish community, Spanish speaking, and the problem we have, like I've said many times before, is how to help the workers. The majority of them are under shops underground, shops that don't have licenses.
Right.
We have invest a lot of money, and that's who we compete with. It's very expensive to be compliant. So as you can see, in our area, for example, custom homes, they go to a shop and they have a guy on the front desk, a gentleman who's like a broker. He sells the job, he makes money, but before it gets to him, you got the designers buying the engineered stone, getting kickbacks. Then you got the broker pass it on to a poor worker who's now becomes a contractor. He goes, here, do this job for this much. Mm-hmm. And the poor worker spends all his time, his hours, producing a kitchen for the customer, and there's no rules at all. It's all dusty. They can't even see each other in there. And I'll give you a good example. This week alone, one of my managers here in the plant, he happened to do a favor for somebody, went to pick up a sink at this shop. He told me the guy was wearing the t-shirt pulled up over his nose. That was his mask. Okay, you cannot help these shops. These employees, they need the money, they need to work, and they will do everything. I've done meetings, I got a big screen on my shop just to scare them. And to be honest with you, the only one that really scared them was the one that came on TV on Univision from the Public Health Watch. That's the one it was. Yeah,
Yep.
and they woke up and they started looking at a little different. But we play videos all the time for them, but because it's so popular, so busy, they don't take it serious. And my guys, they have A-frames in the back of their trucks. They work somewhere else for cash for overtime because, you know, overtime for them is not as it doesn't pay out as much as going for cash. And they go on weekends and after work, they work at other shops. So my job is to make sure I'm compliant to the best I can, to make sure I have records, because this is already starting to spread into big lawsuits where I'm going to need to provide all the information because, you know, people come through here all the time and they can say, yeah, I got it there. Well, we put a lot of money into it. I mean, for example, I've got 91 yards of concrete just to build the gutters for recycling water. We have the room, all the cutting, dry cutting is inside of a special room, and it's got water curtains on the wall. So it all flows through the water curtain. They all wear masks. We supply all the safety equipment. When we stop, when we stop everybody for meetings, it's about $3,000 a month. And we are competing. We do work for box stores, which is very competitive. And these guys stay right below their cost. And these custom builders, they'll go to them, the general contractors, and they pay cash. And that's what we're competing with. Any questions you have, you know, Sean's here with me. He can also.
Product. Probably the biggest problem is the way the product's distributed. When I started in the early 2000s, I was right out of college, graduated engineering, but decided to enter the family business. And it was different back then. What it was is the product was sold from the distributor, who a lot of times is the manufacturer. Like Caesarstone, for example, also owned distribution warehouses, or Cosentino, Silestone. The manufacturer, no matter which country it was, would ship the product into a warehouse, and then they would send somebody to get your shop certified. And that didn't necessarily mean safety. That meant they just wanted to come and make sure you weren't doing it in your backyard, that you had a saw. It wasn't what we're talking about today. It was making sure it was a place. Making sure it was a place that could work on the product. And then what ended up happening over time is greed and sales, and everybody wants to sell more stuff and make more money, took over. And probably I would say, you know, around the 2010 mark, the product started getting distributed to all different kinds of channels. And that means that it can be sold to resellers, sold to people that don't even cut it, sold to a reseller who sells it to a reseller who sells it to a reseller. Like, the product just became wild, where anybody can buy it, and it's a wild, wild west. A homeowner can buy it, and they could go and they could buy the material, and they don't even know where it goes. They buy the product, they go put their credit card, they buy it from a place, the place ships it in, some guy picks it up, which is, you know, a lot of the smaller shops that they're not even certified. Nobody knows what equipment they're using. So the industry kind of changed, where the distribution method of certifying a shop and it going from point A to point B became irrelevant, where now it's whoever wants to buy it can buy it, and whoever's picking it up is picking it up to show your receipt. And that's kind of where we're at today, where that's probably the biggest problem. Is any of you could probably drive 20 minutes, and if a place is open, buy a slab. And your contractor has a guy that you might never even meet that is going to go pick up that slab. And you might actually be purchasing the product, you as the owner of your home, and you don't even know you're buying it and having it sent somewhere. And that's the problem, is nobody knows where everything's going. It's just going everywhere. So that's probably the biggest problem. The technology is the other part of it. Is as shops evolve, they implement more technologies, and you can fabricate a kitchen by hand 100% dry in a backyard. You can do it, but that's the most crude way to do it, right? Without technology, you have one tool, a blade, and and glue, and you can do that. But as companies implement more and more technology, you start to see the process gets more automated and pushed where we have robots cutting it now, just like a Tesla factory is moving cars. We have a ballast where we could actually put the slab underwater and cut it. The ballast will raise the water level above the slab, and the slab's underwater being cut. I mean, there's a lot of technologies that are out there, but they cost money. The more and more technology you have, the more automation and all the manual cutting, where I saw on some of your slides, the percentage of the type of worker, where if a lot of the manual work is being done by hand, if we can pass that to machines and automate it, the automation part tends to have lower risk than the person working in the backyard in a very crude way. But the technology costs money, and you have to know how to use it and fix it, which is its own challenge. So
Yeah, so can I ask you guys, can I ask you a question? Do people in the Northern California, I used to live in Berkeley, so that's why I'm asking this question. Do they know that you are using safe methods? Are people talking about that as something that should be given more weight in terms of your business opportunities, or are people totally unaware of the kind of investment that you've already had to make in order to give them a safe product?
They're totally unaware, because the market is usually, it's a reselling market. So like normally you don't buy the product. You could go buy your own slab, but the person that's working on it, most of the time, like even us, for example, if you walk in, we have 16 Home Depot stores across the Bay Area, and you could go in and buy your product at the store, but you don't even know who we are. That's usually the case. So most people don't engage directly with the fabricator. They engage with a design, a little kitchen bath dealer, a designer, a contractor that's already on their job doing the whole house. Could be a box store, but when you get to the bigger companies, there's more exposure, so they tend to check to make sure it's a little bit more legit. The biggest part of the problem is the cash black market, because a lot of contractors, and they're paying people cash and picking up the slabs, and they don't know any of that stuff. It's kind of in the back closet. Nobody's looking inside that closet.
We did lose a lot of employees.
We've lost a lot of employees because they don't have to pay taxes.
They say your overtime, we don't like it. They say, well, they pay us half cash and half check. And this is,
well, it's better, because then they can also apply for state benefits at the lowest wage levels when they're getting cash, not paying taxes. And it's like, well, why would you go work for a legit company like ours when you could go work for cash, show almost no income, and get everything that our state offers?
And one thing that I know, all this, everything I've heard here so far, like I've said many times, there's only one way to fix this. There's only one way to fix it. And it's the source. When it's being sold, it should be verified, not by walking into a shop, but by looking at the records. And that person's, if the problem with the manufacturers is they compete. So they're not going to do, if they do that, they're not going to sell material. So if the law is across the board and they all have to do it, you will fix the problem, because now you see where it's going, just like any chemical that's dangerous. You see where it's going, you verify. It's your job to verify that fabricator. If something happens, you're responsible. That's what needs to happen.
The market has bifurcated into two segments. You have the segment where it's the bigger shops that are for the most part, trying. Let's just say trying. I've walked some of them, and plus minus. And then you've got the whole gray market. And the gray market, I think, is where we have the bigger problem, because there's literally nothing being done, I think, in that avenue. Whereas, like, we used to fabricate for IKEA, right? IKEA has iWay, which every factory in the world that produces, even if you produce a pencil for IKEA, they send somebody and it has to meet their iWay requirement, where they walk your shop. And they walked our shop, and we actually got the highest score in the US, but we didn't have an emergency emergency bell, because in factories overseas, it's more of a problem where the infrastructure is not as built as in the United States. And you need to have an alarm for people to get out of a building that's on fire. That obviously we have fire codes here, but like things like that, where these products are going to places that there's even some buildings where it's not even one company. It's one guy selling his services in one corner, and they're renting corners out. It's really out of control, is what it is.
One more thing, the cabinet shops that do the cabinets, now they see the countertop being done by somebody else. So what do? They pay a guy to work in a back room and fabricate one kitchen of them every 2 weeks. And that guy's busy full time, and he's breeding Silica full time. And he's got the job, and we don't, because he has the control to the customer, that he reaches the customer before we do.
A lot of the distributors actually started, if you ever go into like a boutique dealer, every major city has one. You'll find they sell natural stone, they sell beautiful stuff, but then they have quartz, okay? But then they've got all these little business cards of all the little guys that they're funneling. It's like a little ecosystem, but the ecosystem is not doing any of what you guys are talking about today. We have to, because we work with Home Depot, we work with publicly traded home builders, we work with IKEA was one of our clients. When you get bigger, you have to be big to be able to do the volume, but you also have exposure. So these are the things that we care about. But that whole other part of the market that's developed over the last decade is basically out of control. And the sad thing is, a lot of people buy the product and they don't even know they're hurting someone. And
you don't know who these contractors are. The face could be a JC, or a cabinet contractor.
And it's the GC friend that everybody's done their house with, and my aunt did, and he comes by and says, go buy your slab over at one of those places over there. You go run your credit card, and that's where the magic starts. Who's picking it up, and where is it going? Nobody knows.
So let me just interrupt for a second, because there are two people who I would like to sort of bring into the discussion, if I may. Dr. Fazio, I know you're in Southern California. Is what Manny and his son are talking about, is that really the case in the workplaces that you've been investigating? And the same question to a certain extent is to Alma. What is it that could be done to improve the raising of the alarm for most, as we assume, most of the workers at risk here are Spanish-speaking workers. They're here trying to support their family, both in the United States and back home, whatever country they're from, Salvador or Panama or Mexico. Are there opportunities to move the prevention part forward from either of your perspectives? And I apologize for putting you guys on the spot, but that was the reason that I wanted to have, if you will, this roundtable. And we've got people, as I said, who are right there where the rubber meets the road, and you are part of that too. So just like to throw it up, and don't, Jane, you got your mute off, but Alma, you need to unmute if you want to ask a question or provide a comment.
I just wanted to say I'm really glad to get that perspective from you both. I've talked to a lot of folks, almost every week or two. I have a couple of patients in my clinic with silicosis, and I talk to them about their jobs. And the majority of the patients that I see and that are in this cohort that I described are working in small shops, and a lot of them are not necessarily employed by one single person or in one place. And so to what you said about sort of under the table kind of underground work is very, in my mind, very prevalent, at least anecdotally. And I think this, like you said, the overhead needed to, create safe workspaces can be extraordinary, especially for a small shop. And so I think, there's a lot of guys trying to balance like immigration concerns with taking care of their family, with trying to keep themselves alive. And so I think they're just trying to figure out the best way to do all of those things. And it's really complicated. It's really complicated psychosocially. And I don't know. I mean, I think it's really helpful to have the business insight from you guys, I think, because I think it gives us all a lot of perspective on what we can do going forward. And the thought that, you know, we can rely on just, you know, shop inspections and regulations is false. You know, I think it's the safety of the materials, it's the regulation of the material before it gets in the hand of anyone that's going to do anything with it that needs to change, in my mind, at least in the United States, especially to protect these men who, you know, have young kids and are in this country, and really that's the risk for them. And so I think, I don't know, I'm sort of on a limb here, sort of just talking around myself, but I'm just really grateful to hear from you guys. And I don't know, I'm sure Alma has something to say as well.
Yes, thank you. Thank you for doing that, Dr. Fascio. From my perspective, it's a systemic issue here, because the immigration, we need an immigration reform, definitely. A lot of the workers, the essential workers and workers with low wages are immigrants with no legal status in the United States, and of course no insurance, medical insurance. So it's systemic in the sense of they don't pay taxes, they need to earn a little bit more money, they need to work more and then send the money over there because their family is depending on them. And but again, I'm going back to knowing what they are thinking, what are they valuing. And if you make them realize that what they are doing now, that is trying to provide to their families, is going to end very soon. If they are not healthy, you know, things will be better. But in this world where the workers are disposable entity in a way, you know, they just work until they die. And it's not only with silicosis, I think it's with a lot of different diseases that are there, you know, chronic diseases, ergonomic injuries, you know, a lot of different things. So I think we need to rethink, everything is connected, and rethink about the entry point to provide prevention. Somebody was mentioning about the SDS, you know, the worker protection standards that are related to that, but all those things are in different, in a language that even somebody from a PhD can understand in the United States. So we need to think about that. And also the other part is to think about the consumer. I think the consumer also need a lot of information. If they know what is happening behind what they are buying, is a different, but we need time. It is a process, it's not easy. So we have a different levels of education, change behavior, change paradigm shift. Here we are thinking consumerism, the most cheap that you can find, or less expensive, you will buy it. If it's an offer, you will go and buy it. You don't care, you know, from where it comes from. So those are my thoughts about it.
So Ryan, can I ask you to, if you will, sort of give us a perspective, if you will, compare and contrast what employers in Australia have done or not done based on some of the research and findings that you shared with us earlier. Do you have the same kinds of problems that Manny and his son are talking about in terms of smaller shops that are, if you will, under the radar, that are trying to cut corners like crazy and make their workers sick? Or are people sort of willing on a social basis to say, yeah, we have to do something or we have to do more to protect the workers, to keep the silica dust under control. And I'm going to ask Kevin Hedges to think about the same from the Canadian perspective. But I know, Ryan, you've been at this a lot longer, I think, than most of us. And I think we would benefit really from hearing what you have to say.
Yeah, thanks, David. No, this was great to hear from Manny, and it's same stories. I think probably the difference, I think are probably 3 years ahead at the moment, and obviously we're dealing with a smaller population, smaller industry here, which is more manageable in terms of the regulations and the interventions from the regulator. Certainly here in Victoria, there's been quite a lot of interventions by the work health and safety regulator, going out and finding these businesses. They've developed now, there's been a law that's very clear that the dry processing of stone is banned. Then there's hefty fines associated with it. If an industry, if a workplace there's dry processing in, it's hundreds of thousands of dollars the fine for dry processing. And it's an activity which is obviously very obvious to workers now that it is hazardous. So I think that's part of the communication that the regulator's been quite successful at getting across, is that this is an extraordinarily dangerous work practice. There's been introduction of a licensing scheme for the industry in Victoria, where every workplace that buys and sells engineered stone needs to be registered with the government. And there's a dedicated silica field team that goes out and visits these sites now. So, we've got the advantage of being smaller and these interventions being able to be more effective. But yeah, listen, there's still, the micro businesses, the backyard operators, which are still cutting dry. I hear this, day in, day out from employers and other workers in the industry that are doing the right thing. And, to me, I guess a reflection of some of this discussion is that, the last 20 years has been just this unchecked growth of this industry and use of this material. And it's only now that we're seeing, from a health point of view, the impact of this. And really, I can't think in developed countries a more dangerous industry than what we're seeing in the countertop industry. So, now's the time really to act upon this. And I don't know what the solution is, but we always think about the hierarchy of controls, don't we? And, elimination is number one. And, engineered stone's a material that's been with us for 20 years, not, hundreds of years. How do we roll back the clock and get this out of the industry? It's going to be hard, but I think that needs to be the end game, really.
Yeah,
David, if I may interject there, the situation and what Manny and his son has described is exactly what we experienced in Southeast Queensland when my clinic on the Gold Coast actually described the first cohort of people who were suffering from this. The regulations were then introduced in Queensland, but the business just moved across the border into New South Wales. So the backyard operators are a very real issue. One of the hardest things I had to do as an occupational physician working with workers in this game is dealing with the business owners like Manny and his son, who are doing the right thing, but because of labour shortages, they weren't able to meet demands of the market. The backyard operators, the people who were cutting the corners. So even when you have a regulatory environment that wants to do the right thing, regulation by itself, education by itself, it doesn't solve the problem. So we need the combination of strategies to support those businesses who do the right thing, because the product can be actually fabricated and installed safely, but only if it's done properly. And so I feel for Manny and his son, because they do the right thing, and all it does is open them up to the ambulance chasing lawyers who will actually then come in and see them in their shotgun sights.
So let me interrupt for 2 seconds to welcome a couple of very good colleagues, Bob Harrison. We already talked about you, Bob, because we know that you're in Scotland and that you've been spending the night rather than listening to us, doing some Scotch tastings, and I'm certain that this is going to be reflected in your comments. But we also have Dr. David Weissman, and I'd like to just ask the two of you to share with us some of your thoughts about where things are, where we need to go. I very much appreciate Dr. Fazio's comments about what she observed, which I think is, in fact, a reflection of what Manny and his son were talking about. But it's down in Southern California, which apparently has a lot more of these small shops and got a bigger population too. Anyhow, Bob and David, please join, if you will, talk a little bit about where you think things are and where we need to focus our attention going forward.
Thanks, David Goldsmith. David Weissman, I'll toss it to you first, as my respected NIOSH colleague.
Well, gosh, you beat me to it because I was about to say exactly the same thing. but
you mean Dr. Weissman and Dr. Harrison have been drinking the same Scotch?
And I didn't even have to go to Scotland to do it. So there we go.
That's right.
But seriously, I think one big difference between Australia and the US is the great job that Australia did of identifying cases and of creating urgency, creating the feeling in the country, you know, in the media and in the population, that this was something that was urgent and really had to be dealt with. I'm really concerned that I think everyone on this call knows that there are a lot of cases out there in the US, and yet, you know, we have like probably less than 100 cases reported in the US that we know about. And we're earlier in the webinar, it was estimated that there were maybe 20,000 cases in the US. So where are they? I mean, if they're not, you know, they have to be in places other than Los Angeles. They have to be, you know, throughout the US. So we need to do a better job of finding cases and getting the public health surveillance out there so that people recognize that this is a big problem in the US too, to generate urgency to deal with the issue. And then I would also agree with others that have been on the chat that this is about prevention. This is about, you know, we know what causes silicosis. We know how to prevent silicosis. And probably the most effective way to prevent silicosis is to substitute for or eliminate the hazardous exposure. And you know, and so if we're not going to have good product stewardship, if the issues that we heard about are happening and the manufacturers aren't making sure that this hazardous material is used properly, you know, if we don't have product stewardship, you know, then we need to substitute less hazardous materials into what we use. So I guess that's my thought about the big issues.
Thanks. This is Bob Harrison. I work with Dr. Fazio and the other team folks out in California. And I just would say that in the last month, we have probably spent close to 200 hours searching and locating the stone fabrication shops in California. So that's one state, 50, we have 50 states in the US, we're 10% of the US population. And it took us a couple of hundred hours just to find the fabrication shops through a manual Google search. Looking at advertisements, it's the equivalent of, you know, 30 years ago, to find out where hazardous materials are used, looking at the yellow pages. And this just shouldn't be the case in 2023. By the way, we estimate there are probably about 600 to 700 of these fabrication and installation businesses in California, and we're probably missing a number of the informal fabricators that were mentioned. I have no idea how many of those there are. So in terms of policy interventions, I really want to compliment again, as David Weissman did, our colleagues in Australia, because your guidelines, I don't remember, Graham, what the title of that document is. I've read and reread that because it really, I think, is a good roadmap to registration and formalizing the fabrication installation business, such that the manufacturers who sell these products into the marketplace are ultimately required to track and to sell to shops that make sure their workers are safe from silica dust. There's a parallel. I also have been thinking in the environmental movement of cradle to grave, which is a real policy that's been enshrined in many ways in environmental pollution regulations in the United States, and I don't know about abroad. And in this case, a manufacturer can sell to a fabricator and the consumer buys the product, but has no idea that the fabricator who's making that for the kitchen counter is critically ill in the ICU from progressive massive fibrosis. Just absolutely has no clue. I know, and I feel terrible, but the consumer has no idea. And so I think from a policy perspective, I'm really looking at parallels in the environmental movement and thinking, okay, how can we make the case that product stewardship also applies to protecting workers? There's a lot to learn from Australia in that regard. And I guess I want to ask Graham if he's still on the call or for somebody else in Australia. David, will you give me permission to ask Australia or Graham or somebody? I know that Australia was considering banning engineered stone, and the Australian government has decided not to, and is going for a regulatory educational approach. Can you give us like a 2-minute background about why that is? Is it just politically impossible?
Yeah, it is possible. Basically, it's all about politics. The bottom line is, and as Manny and his son has described, the product can be fabricated safely. Once it's installed, it is a very good product. As a consumer, I have it in my kitchen. When I installed it, I know that at least 1 out of the 4 workers who were fabricating my benchtop is dead because of my purchase. When my mother wanted to install the engineered artificial stone into her kitchen, as a consumer, I got to choose the fabricator because I knew that particular fabricator was doing the right thing. But to come back to the issue of regulation, the task force recommended that unless there was demonstrable compliance with licensed sort of processes, then in July 2024, the product should be banned. Now, that timeline has been put out because of our process, but that's still on our agenda as from a health industry, that if compliance is not demonstrated, then we have, because there is no manufacturer in Australia, we can actually ban its importation. So that's still on the agenda. It doesn't get the headlines that it used to, but rest assured, if we can't get the regulatory environment and the licensing schemes up and operating, the health professions here will continue to agitate for that.
So can I ask you, Bob, you mentioned, I believe, something to me in an email last couple of weeks. Can you briefly describe, if someone has a case of acute silicosis diagnosed in California, do they have the responsibility on their own to come up with the $1 million needed if they're going to have a whole lung transplant surgery to replace their damaged lung, or is there some way of providing some public support so that the workers can get the appropriate medical treatment?
I'll briefly answer, then I'll probably toss it to Jane.
Okay.
I was struck, Jane, by your data that I think only 7 of those 52 had filed for workers' compensation benefits. The rest were on public insurance.
Yeah, so I think it really boils down to insurance status. And California is probably the best state to come to, actually, if you are someone who may not have documented status and want to seek medical care and or a lung transplant. We have a lot of laws in California that do not exist in other places in the United States, which is probably why we're even finding the cases that we have found. A couple of those being the expansion of Medicaid. It's the sort of government insurance for people living under the federal poverty limit. California is one of the only states that has expanded that to include everyone, regardless of immigration status, between either under the age of 26 or over the age of 50. And that's sort of been narrowing over the last couple of years. Like the age range is coming to a point where in the next couple of years, I kind of expect that to be the case for anyone of any age in California, which is extremely unique to California. I mean, I practiced in Georgia before this, and there was nothing even close to any of it. And so I think the amount of social support and social safety nets that are available in California are far and away greater for immigrants than in any other state that I know of. Maybe New York would be second. So what I've been doing is the unfortunate part is that most of our folks are not 50 yet. So they are in sort of this window period where they're not really eligible for anything besides emergency insurance. And so what we've been doing is actually applying for something called PRU-Call, or People Under Color of Law, which is sort of a deferred action on the part of immigration enforcement based on someone's illness, i.e. we basically write a letter saying that they're too sick and would die if they were deported. And that if that's approved, then they become eligible for benefits, which include full Medi-Cal, which does usually pay for the majority of lung transplant. Obviously, there's a lot of extra costs that are not just medical costs that are involved in getting a lung transplant, but it would pay for the bulk of the hospitalization, the whole workup, and then the surgery and the hospitalization, et cetera, et cetera. And so we've basically found ways to get that workaround in the state of California, which is just unheard of, I think, for this population in any other state, based on talking with colleagues and other pulmonologists throughout the US. So that gives you maybe a little bit of background on what we're trying to do. But yes, it's an uphill battle to get that insurance for them.
Good. Kevin, really briefly, is there anything that you can sort of share with us about how the Canadians are addressing this? What kinds of issues or roadblocks or policy focus seems to be under consideration? If you can share anything about that, I think that would help.
I guess there's three words there. I don't know. Just listening to Bob Harrison, talking about California and going through the phone book and spending 200 hours, and maybe somebody else. I live in Canada, but I've got close roots with Australia. Hence, connecting, like reaching out to Graham and bringing, the Australian folks into the mix. I just want to mention one thing, though, or a couple of things. The first thing is, it was interesting to see Jane's presentation. She had a slide, so it's like a fabrication shop, and the workers were wearing, there was water suppression, there was also localized exhaust ventilation, and there were also respirators, and they were wearing elastomeric respirators. And I see there's been a lot in the chat, that can we actually even fabricate the materials safely? And I don't know the answer to that question, and hopefully, the webinar on the 13th, we can explore that more. But I think we really need to swim upstream And I think what Australia is doing, the regulations and the licensing, we can learn a lot from that. And if I can add one other thing there, just Mahinda put an interesting comment in the chat box. You know, we're all about underserved workers and populations, both in developed economies and developing economies. So, you know, what about the other countries out there? And can we leverage some of the learnings here and share that with people in India, for example? So that's, but as far as Canada goes, there's other occupational hygienists like Lydia Renton that might know more than me. I see Melanie is on the call too, and she's probably closer to the mark than I am, but I don't know what's happening in Canada. Thanks, David.
Yeah, here's a point where I very much like to just open up the discussion. You know, I want to come back to you, Manny, and because you really started us off. Were there some additional points that you wanted to share about how your business is going, how you expect things to go, let's say 2023, 2024, given your level of knowledge and concern? Are you optimistic? Let me just, how about if we put it that way? And I'm going to do that, and then we got a couple of raised hands, so let's try that first.
Hey, David, this is Audrey.
Yeah, please.
After that, there's a lot of questions in the chat room. I'd like to have some time to read some of the questions to share that with the group.
Okay.
We're kind of running out of time, Audrey. It's nearly 7:20, and this
Yes.
webinar finishes up at 7:30. So I don't know if we'll have time to do that. Maybe we can, you know, the webinar on the 13th, we can revisit some of these questions as
Okay,
well.
yeah, maybe just put some time in the agenda because there are a lot of really good questions. But yeah, it is late. You're right.
So with regards to the insurance, one thing that we did find, especially after the Australia, because I kind of saw what was going on there, is a lot of the bigger manufacturers were sending contracts to fabricators to sign because it was found in, I'm not an expert in what happened in Australia, but there's no insurance for the legal stuff that happens, the legal repercussions. So what we're seeing is a lot of the major vendors are sending us documents that say, if you want to still receive the product, you have to sign a document that says you're going to indemnify us. So what I'm thinking is happening is the manufacturers know that they have no insurance for silica or coverage. Nobody does. What they're doing is creating an insurance pool by having all the fabricators sign this document that says if you do get the ones that are legit, not the other part of the market, they say, they kind of twist your arm and said, well, you're not going to get the product anymore unless anything legal happens to us, you have to cover us. So that's what's been happening the last couple of years, pretty much since that Australia thing happened there, right? We started seeing all the documents come from DuPont, Caesarstone, Silestone, LG, Cambria. Every manufacturer is basically trying to create an insurance pool from all the legit fabricators now. And one thing we noticed, and actually a friend company in the area that does Monument, and I saw a lot of stuff regarding sandblasting, is we went up for insurance renewal and almost every single insurer said, we're not even interested in bidding for your business, where previous years we would have 5 bidders, 6 bidders, right, that wanted the business. And this was the first year. And the interesting thing is our friends at the Monument Company, which we really don't interact with much because our products are different, customers are different. They had the same thing happen where all the insurance companies wouldn't. And then I called a competitor and something's going on the insurance side where they don't want to insure stone shops. We're seeing that the only one that would take us was our current provider. Everybody else refused to bid. They weren't interested in the business, which was very odd. So looking forward, I think that's going to be a challenge, getting insurance if you're a stone shop. That makes that bifurcation between the gray market and us, companies like ours, farther apart from each other.
That's workman's comp.
And that's the word.
That's workman's comp. General liability, nobody has insurance for Silica. Workman's comp is ending, and I think by next year we might not even be able to get it.
Yeah, unless our current provider. So nobody wants to bid this business anymore to insure it
because of the cost.
or they know something's coming.
Monona, you had your hand raised. Rosal?
I quickly typed it into the chat because I figured I wasn't going to get time, but this is only take a second. I have some experience with laser jet cutters and with underwater cutting devices. Please don't call them safe. Call them safer. The fine mist that goes all over, it's a silica containing mist. It settles everywhere in the shop. The whole shop ends up gray with these dried particles of mist all over it. So there have to be hygiene procedures and some kind of respiratory protection with those devices as well. Okay.
That's a strong, good point to know. Lawrence, come and ask your question, please.
Thank you. With regard to what Monona just said, in my experience going into the manufacturers who make this stuff, the principal problem that I've seen is the leftover that's on the walls, and anytime the building shakes, the stuff comes down. And these are companies that have water suppression for manufacturing architectural stone, which is huge, huge stuff. The second comment I'd like to make is that you asked about Canada. In British Columbia, the Workers' Compensation Board, WorkSafe BC, within its regulations requires suppression at source for any kind of silica or hazardous material. So we constantly see water suppression, and we also require hand tools to not only use either water suppression or point source ventilation to capture before it gets to the workers, in addition to fit tested respirators. Now, many jurisdictions have those kinds of regulations, but I see consistent application of those regulations by the inspectors of WorkSafe BC. They're pretty good at doing it when they can inspect and when they do get calls to go out and inspect. So that's what I have to add to the conversation for now. Thanks.
Appreciate that. Graham, please.
It's important to remember that the aggregated size of the particle that's actually getting into the lungs is a really important piece of the puzzle. You know, when you're fabricating with a angle grinder or a saw on a dry product, you've got high impact, very small particles being generated by the fracturing process. In the settled dust, you've already got aggregated particles that are no longer in that respirable fraction. And so they aren't getting into the lung. So while there is no such thing as a safe process, which I endorse Mona's comments, it's important to remember that process controls using surface active ingredients in your water so that you are promoting aggregation of the respirable fraction is an important component of the process of controlling and making safer the processes of fabricating. So you know, I have yet to find any case of silica related pathology where there has been compliance with the workplace standards of the day, ever alone the workplace standards of now. So if anyone knows of a case where they were compliant with workplace standards for their working life, which is pretty rare, and they ended up developing pathology, I would be very keen to know.
Let me just ask you all who are still, I mean, and there's still 148 of you on the line. Do you have some other questions for our panelists? I am very sorry that you know, we lost the publisher of the article. He's somebody I've known for more than 2 decades, Jim Morris, because he didn't have any power, wasn't able to really to talk about the issue about what the press coverage does and what his intents are. Nevertheless, I still think that's an important topic for us to be aware of. But if there are other questions, if you could please just signify by raising your hand. I know you guys can do this, but if not, it's been a long day and a very good 2+ hours. I am delighted as your host to have such strong presentations. I'm sorry we missed a couple. That stuff happens. We got families. We got Scotch tasting. You've got to pay attention to all of those things. Please, if you have a question, yes, please go ahead, Alma. Do.
I just want to make a point referring to one of the comments. From the epidemiological point of view, you need to consider not only the cases here, but the cases in all Latin America or in the countries where the workers are coming, because a lot of them, because the status, once they get very sick, they go over there and die over there. And the diagnosis, or there is a misdiagnosis of what is the cause of the death. And I will, maybe in another occasion, we can talk about the multi-level approach that we need in order to resolve this. I think epidemiologically, we need to work on that, legislation, immigration, a lot of different things, and also working with the consumer and with the worker in terms that they understand. That's
and I'm really glad that you restated that. You and I exchanged a little bit of back and forth on the chat, but not only do we need to have good communications with immigrant workers who are in the United States or Canada or any other country, but then those workers are going to move, and they're going to move back to their home countries or to their home communities, and their physicians, the people who are caring for them, need to understand what kind of an illness they have. And secondarily, we know that countertops are being made in Mexico, in Cuba, in all over South America. And, because those physicians and those healthcare providers and nurses are not on the call, doesn't mean that they are not seeing those problems. I am positive that they are. What we need to try our best to communicate effectively the seriousness of this problem to them as well and you are absolutely right. That needs to have both hands on the wheel. One is to the workers, and the other is to their healthcare providers, so that we can gain information and help translate what we know into something that is useful for these patients. Kevin, please go ahead.
Yeah. I just want to say that, what we're trying to do is distill out all the learnings from these webinars, and hopefully the next one will be more on prevention. And we'll kind of distill some of, what we're seeing in the chat, what we've heard. And we've also got Dr. Sue Hambling from the UK HSC. So she's a specialist inspector, and she talked about, looking at different interventions and that. So, with regards to prevention and what works and what doesn't work, please, if you've been on this webinar, join us on the 13th of February. And that's 4 p.m. EST, which is 8 a.m. Australian time. So it's makeable for you guys. And Jason Green's also going to be co-presenting along with Dr. Melanie Gorman-Ning, and she's going to be talking more about the Silica control tool. That's all I have to say. Thanks.
Much thanks to all the speakers. It was wonderful.
Yeah, and let me just add one other thing to what Audrey said. WHWB is really, as far as I know, the only group. We've got no profit making involved. We've got no salesmen. We got no drugs to peddle. What we are in the business of doing is transmitting what we know, so that patients who are citizens of whatever country or immigrants to whatever country we're talking about, that they get as much prevention and healthcare as we can provide, and information about these kinds of hazards as we can provide to them. And I also want to extend my enormous gratitude to everyone who has contributed tonight. And, I know there's been a lot of chat back and forth. And if, I've not been able to reply, but please feel free to contact me if you have questions. I'd be more than happy to respond to email, and more than happy to talk to folks on the phone as well. Thank you very much, everybody, especially those in the time zones where you should be asleep, and for those who have stayed on, and I can see there's still 131 of you. I cannot express how grateful I am for your interest and concern. And let's see everybody back when Kevin is leading the band on the 13th of February. Thank you all, and have a terrific night or terrific day wherever you are.